Okay, welcome everyone. This is Fred Riccardi, president of the Medicare Rights Center. For many of you, you already know this, but we're a national nonprofit organization and we work to ensure access to affordable healthcare through direct service, through educational programs, and through public policy initiatives. You may not know this, but we are based in New York City, so you might hear a few sirens in the background. And today we have a very special guest, Tim Engelhardt. Now, Tim has spent over 25 years in the field of healthcare and most recently led the office of the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. I'll try to cut down on the acronyms today. And Tim has spanned multiple administrations while at CMS, and now he is the executive director of the Aging and Disability Policy Lab. Welcome, Tim. It is good to see you.
Thanks for having me, Fred.
So today we're going to have an important conversation about Medicare and Medicaid, how these programs work together, how they don't always work together, and most importantly, what does this mean for people who are enrolled in Medicare and Medicaid? And what can we do about it? Now, Tim, just so you know, we have a diverse audience today of Medicare beneficiaries, policymakers, advocates, professionals. We're over 500 people who've logged on, so welcome and thank you for being here. And I know it's my goal to be learning from Tim today, and so just thanks everyone for joining us. And so, Tim, I want to kick it off with what brought you to this work since you've been involved in it for over 25 years? What brought you to it and what drives you today?
Well, I started many, many years ago. My first real job was for $29,000 a year and no benefits with the Maryland Department of Health and Mental Hygiene. And I came into it out of college. I had every negative bias against government work and government bureaucrats you could possibly have. And I thought of it as this like easy job where I would punch in and out and I would do this for a year or two and then I would move on to something much more important and ambitious. And instead, I found myself surrounded by people who were brilliant and creative and incredibly committed. And in hindsight, like we did many things wrong, but I am endlessly grateful for the fact that I started in state government around a group of people who I still love and respect today, who taught me so much and taught me like the value and importance of public service. So that's where I started, and it was only happenstance that I ended up focused on the particular things that I would end up spending the next couple decades focused on. What keeps me going, in addition to being for a long time surrounded by great people in this field, are like the little moments where you feel like you actually make an impact in someone's lives. And in government, sometimes you're weirdly divorced from that, and sometimes you're doing it at an incredible scale, and that's an awesome responsibility.
It really is. And Tim, as I was thinking about our conversation today, we've been in meetings together, Medicare Rights as an advocacy organization and your role in the government. And what reminds me and drives me is the connection that MMCO has to dual eligibles on the ground. So at Medicare Rights, we provide direct service, but we also work on public policy initiatives. And that really came through to me over the course of many years at MMCO, that we started to see that dual eligibles really were being centered in these policies. And what was exciting for me, not surprising because of who you are, but what was exciting to me is after your time at CMS, you graciously offered to volunteer on our helpline at the Medicare Rights Center. And I was really thrilled about that because I wanted to have you listening to the unique experiences of our helpline clients. So, first of all, why'd you decide to do that? And did you learn anything from it?
Okay, there was nothing gracious about it. It was totally selfish. I have worked in Medicare and Medicaid for a very, very long time. And yet, among my many inadequacies, I was totally useless to my own family and friends. I couldn't even help anyone pick a Part D plan or tell them when to enroll in Part B coverage or anything. So attempt to overcome some of my own inadequacies, I signed up to be a volunteer with the Medicare Rights Center. And for others to know, I didn't do it by contacting Fred. I did it through your website to your volunteer coordinator, Max, who's incredible. And then Max graciously accepts my email and having no idea who I am. And he tells me I have to come up to Manhattan for an afternoon of training. And I came. And it was pretty high level. I felt pretty good about myself during that day. I assume mostly this was to screen me out, make sure I was serious. And then as I'm coming home, Max says, well, now you have to complete 28 hours of online training. I thought, whoa, 20 hours. But I'm feeling good about myself. And I've been in the field for a long time. So I think I'll bang this out. This will be a piece of cake. And instead, Fred, this was the greatest intellectual challenge of the last 2 decades of my life.
Really?
The first, I want to tell everybody, your Medicare Interactive Pro trainings, which is what I think I took, are incredible. Everybody who has staff in the field who work on Medicare issues should buy this from the Medicare Rights Center and get their staff to take it. I think everyone at CMS should have to take it too, because it's incredible training. But also, like, I got into this and I realized there was so much I didn't even know. I didn't know. And so it was just this incredible, just this incredible process. After which,
Mhm.
then I still had to go through like multiple months of shadowing and training with your call center staff before I would even be like allowed to talk to a human being on your helpline. So there are multiple takeaways from this. One, the Medicare Rights Center runs a tight ship, and has an amazing staff for which I commend you. Number two, Medicare, you know this, and I thought I knew this. Medicare is far more complex from the beneficiary's perspective than I understood. Okay. Again, many of the listeners to this already know this, but there are elements of decision making that start with even when you enroll in coverage, uh, that get increasingly when you accept your ESRD coverage, when you also have employer coverage. I mean, so many things before you even get to the stage of having to navigate the dozens of choices you have among Medicare Advantage plans or Part D plans or whatever the case may be. So, it helps to bring home that like the optionality in the program has some benefits, but it is so easy for people to make bad decisions. And the learning costs for like real people out there are enormous. So Medicare is more complex. This is also like personally humbling for me when I still uh, get the chance to participate in the helpline, because to be clear, I have a supervisor every Thursday morning when I'm on the helpline. She cannot be half my age, except I call her desperately with questions repeatedly because like she knows twice as much about how to help people navigate the Medicare program as I do. So shout out to Maya, my supervisor, who's like amazing. And, and then more importantly, like it is genuinely and profoundly disenfranchising for Medicare beneficiaries, when they cannot reasonably effectuate their own rights and protections when they're in a system that they cannot possibly understand. And I think way on the policy side, we fail. I am living evidence. We fail to appreciate all of the decision points and challenges that people face. But I think members of Congress, like I think we fail to appreciate just how disempowering that can be for people, even for people who have every unearned privilege and advantage in life. It's overwhelming, much less for others. Another takeaway, CMS, the Centers for Medicare and Medicaid Services, where I worked for a long period of time, and which oversees these important programs. Like, CMS does not focus enough on some of these like experiential issues. Now, that's partly because the Social Security Administration handles Medicare enrollment, but it's really clear to me in hindsight that we haven't well aligned the federal focus with the issues that affect like the great majority of people as they enter these programs. And then last, I knew this, but it is brought home that the range of problems and challenges in people's lives it is infinite. There is no boundary to the number of challenges that people face, and you and your team on the helpline like face that and deal with that every day and do an incredible job of it.
Yeah, Tim, first of all, thank you for that reflection. First of all, I'm glad that Max like put you through your paces and made you do the training. So that's excellent. Go through the whole thing. And that resonates with me because when I'm listening to beneficiaries and we're training new folks, I say, here are the policies, and these are the way the policies are supposed to work. But our healthcare system is so complex that at any point in the system, something could go wrong for someone. And then first, we have to figure out what's happening. And then second, point them in the right direction. And part of, I think, what is for me, what is fun, what is challenging, what is frustrating is I often have to prove what I know because the beneficiary's experience has gone so awry. I have to just double check my knowledge before I can share it with them. And I love that you did that. I wasn't surprised because as I had said, out of MMCO for many years, the Medicare Rights Center has worked on ombudsman programs. We have advocated for improvements, and the department has engaged advocates, has engaged health plans, has engaged stakeholders to be involved in this. And so I like to, in my personal life and my professional life, I always like to step back and ask why. Not only like, why are we doing it this way, but why are we doing it? And so as we continue to focus on improving the system, I would say for the most vulnerable, the dually eligible, for people who are enrolled in Medicare and Medicaid, or for people who are just hovering around eligibility for Medicaid, maybe they're eligible for the Medicare Savings Program. Why are you continuing to focus on this?
Well, let's talk about that population first. There are 12 million low-income older adults and people with disabilities who are concurrently on Medicare and Medicaid at the same time. But it's this like incredibly heterogeneous group. Like it's a lot of older adults, right? But a third of that population are under the age of 65. It includes nursing home residents, includes people in their own homes. It includes people with physical disabilities, intellectual developmental disabilities, serious persistent mental illness. I mean, it's this like this great array of different populations. So whatever mental image you have in your head of someone who's dually eligible, it is like limited and wrong to some extent because it's just such a broad group. But by definition, it's a group that's unified at least a little bit by poverty. And so people who are dually eligible, they disproportionately experience the correlates of poverty. Like they're dually eligible beneficiaries are 5 times less likely to have a high school diploma than other Medicare beneficiaries. Now, there are plenty of dually eligible individuals who have PhDs, but on average, it's just like they experience the other correlates that like challenge your navigating a particular system. For 45% of people who are dually eligible, 45% are food insecure, right? So like we have to remember that like before you even get to experiencing medical care, you have to have a place to live and have food to eat. And this is a population that disproportionately has like, major challenges. A quarter of dually eligible beneficiaries have trouble getting places, right? So these are like really important structural issues to consider. And then there should be no surprise that as a population, people who are dually eligible, also relative to their kind of higher income Medicare peers, have higher hospital readmission rates. They have higher rates of reporting that they have poor health, right? There should be no surprise on that. And there's multiple reasons for that. And some are big and theoretical, and some are like crass and specific.
Hmm.
Since the inception of the Medicare and Medicaid programs, there has been like a problematic incentive problem. States have to balance their budgets, but doing things and making investments that help keep dually eligible individuals out of the hospital don't pay off for states because the federal government, the Medicare program, are paying for those hospital costs, and kind of and vice versa. They're like the Medicare program doesn't kind of financially benefit when they keep someone out of a nursing home in the same way that they would otherwise. So we had these like wrong pocket economic incentive problems that are like weirdly and deeply nefarious over the kind of longer term arc of the programs. It's number one. But then it, from its inception, but even to a greater degree every year, that complexity that we started with for both beneficiaries experiencing the system, disenfranchising, causes people to make poor decisions, but also for the government to like run good programs. It is increasingly complex in our like current world. And then emerging over the last 20 years, we have this, I guess, increasing misalignment of resources, and that manifests itself in two ways. One is um, so I'm sorry for getting technical, but most dually eligible individuals are not responsible for paying Medicare cost sharing. right? The 20% for a Part B service, the deductible for when you go to the hospital. And instead, it's the state Medicaid agency who's responsible for paying that. But because of some quirks in federal law, state Medicaid agencies don't have to pay those amounts in many cases. So we often have physicians and others who get paid 20% less for serving low income people than serving high income people. And that's a form of, I think, systematic and social injustice that we too often kind of ignore in the
Yeah.
system. And then emerging over the last couple decades is that we increasingly have value-based purchasing types of alternative payment structures where we put providers at risk for having better outcomes. And I think that we have learned over time that those systems, I think, intrinsically and inherently end up punishing safety net providers who just serve a more difficult population. And so we end up in this cycle where we're directing more resources to those who have chosen not to serve low income populations and diverting resources from those who have. And these are like nefarious cycles that we have to be, I think, really intentional and conscious about breaking. And so there are like challenges with this population at every level, from like the theoretical high level to like the very specific experiences about how people interact with their programs and how providers get paid in these programs. And each of these needs its own interventions to try to meaningfully make a difference.
Yeah, and Tim, to go back to your point around poverty and the experiences of people who are dually eligible. So the majority are very, very low income, uh, still living in the community. But when we're talking low income, we're talking about, less than $1,400 a month. And I think about some of the decisions that beneficiaries are forced to make during the enrollment periods. And it's pretty common for someone who's dually eligible to consider switching, if they're enrolled in a Medicare Advantage plan, to consider switching to a plan that has an over-the-counter benefit card or has some type of financial card subsidy money that they can cash in to be enrolled in that plan. And it speaks to that kind of perverse incentive that we need. People are trying to enroll folks into their plans, and people are poor and they need money, and that's one way they can access it. And so I keep going back to, we've kind of set the safety net so low,
Yeah.
and people are struggling, and there are all of these pressures that are out there, and we'll dig into this a bit more around integration, because someone who's dually eligible may face a challenge finding a provider, like you said, and part of that it may be because of their reimbursement rate, or it may become part of network adequacy issues, etc. Tell me, stepping back for our audience that may not be super familiar with integration, we throw that word out quite a bit, and how do you define integration? And is that still a salient term for you, or what are you thinking?
Yeah, I think it is. And again, this is a term that means different things in different audiences. But for people who are duly eligible for Medicare and Medicaid, we talk about integrated care. And I think of it in like as meeting two criteria. One is it's a system in which I guess people experience one system more than two. So like inherently you're in both Medicare and Medicaid, but can we make it feel like it's one program instead of two separate programs? And then secondly, can we maximally align those financial incentives more around the person instead of around the two different programs? And we have like different flavors of integrated care, none of which get perfectly to solving those two criteria, but each of which like tend to walk us a little bit closer. Many of these are in capitated managed care for various reasons. The Medicare Rights Center just published recently some case studies on integrated care for people who are dually eligible. They're really good. In it, each of the documents you publish, they call integrated care a work in progress, and that's a term I heartily endorse. We have some promising evidence that integrated care improves access to primary care, it reduces nursing facility placement, it correlates with higher overall satisfaction relative to other forms of coverage. But we have, at best, we've only partially achieved like the real vision for what it can be.
Well, Tim, it just made me think about when I started this work, we were counseling folks, and I was learning like what's a D-SNP, which is dual special needs plan. And when I began over 15 years ago, there was very little integration or coordination for D-SNPs. And we've seen that change over time. And, thanks to you and MMCO and other policymakers, we've seen improvements. But going back to D-SNPs, what are your thoughts about D-SNPs? What is the potential there that we haven't realized? What do you think the strengths are? And what else do you think about it? Like what's coming? What do you think is next?
Well, I think I am embarrassed by the alphabet soup of acronyms that in part I helped create, so I like apologize to the broader world for it. I think in this case, though, we can step back. There are millions of people in both Medicare and Medicaid who are in managed care. This is true on the state Medicaid side, often because state Medicaid agencies make it mandatory for people to be in managed care products. And it's true on the federal side. It's not mandatory, but as we know now, more than half of Medicare beneficiaries have chosen to be in Medicare Advantage. And so I'm like agnostic on is managed care good or bad, but it's the air that we breathe now, and we need to make it work as well as we can. So I, is a cop out, but I tend to think less about like are D-SNPs the answer and more about the reality that like we have millions of people who have chosen to be in them. And so we have to improve on what it delivers. And I think that starts with simplifying the market. Again, my apologies for like the confusion that in part maybe we have created at CMS. But we now, 15 years ago, we operated in a market where it seemed like most managed care sponsors were avoiding low-income populations. Now we're in a market in which low-income populations are much more likely to be in managed care now. And there's a very maybe excessively vibrant market of plans that want to serve that population. There's pros and cons to that, but I think we need to figure out ways, the broader policy community, needs to figure out ways to simplify that because it has become too overwhelming for people. And then I, I also think we need to ensure that every dual eligible focused health plan also delivers on the Medicaid side of the promise. And too many D-SNPs offer either zero or minimal coordination with the Medicaid benefits that people receive. And like we need to find ways to change that and make sure that every plan is helping people access the full range of services to which they're entitled.
Well, forgive me if I go a little too technical here with some acronyms, but I do want to talk about, and I'm sure some of our audience members want to hear about the financial alignment initiatives, the MMPs, which were special plans that coordinated Medicare and Medicaid. Full disclosure, the Medicare Rights Center had worked on the New York's demonstration, which was called FIDA, which is a financially integrated dual eligible plan. There were things we loved about it. There were challenges. I'm sure FIDA is not at the top of your list, but Tim, could you just take a moment and reflect on that demonstration? And how many years did it last? Was it 10 years, 12 years?
Yeah, it was a decade before we kind of like we CMS kind of graduated them into some other types of products. Yeah, we CMS at the time created new types of health plans that were intended to be kind of like the most pure possible version of what integrated care could be for people. We had some great successes, we had some great setbacks and great learnings in that part. And I think there are like multiple things that can and have been extended now into like the non-demonstration world. And I'll give you three things that I think are really important to carry forward from that work. One is that this seems so tiny, but when people are enrolled in managed care for both Medicare and Medicaid, oftentimes they get two different ID cards, right? They might be enrolled with two different companies. They get two different handbooks, right? Like, and so before you even access anything, you're kind of faced with this like dueling and confusing reality. And in the context of these integrated care products, we created what we called integrated materials. So people got one ID card, they got one member handbook, they got one provider directory. It seems so small, except I think really profound in how people like initially interact. And the great team that is still at CMS has found ways to make that almost normative in certain types of programs around the country. That's number one. Number two, for a real change in how people experience their health care, we need everyone in those health plans to be receiving all of their Medicare and Medicaid services from the same organization. We call that
Mhm.
exclusively aligned enrollment to introduce even more jargon here. But it's the only way you can have real meaningful accountability for the plans, and you can really like simplify the experience for people. So getting more of the Medicare Advantage D-SNP world to have that exclusively aligned enrollment, I think is a really important kind of structural priority to carry forward. And then third, 15 years ago, there was
Mhm.
almost zero coordination between the state Medicaid officials who oversee the Medicaid program and the federal officials who oversee the Medicare Advantage program. What that meant was like we would step on each other or we would miss opportunities to hold the health plans accountable. We created an environment, imperfect though it is, but we created an environment in which both the state folks and the federal folks began to actually coordinate and share information about how we can hold the plans accountable and how we can make sure they're meeting the needs of individuals. And again, not perfect, but I think finding ways to continue that like very genuine state and federal partnership from which I think both sides learned a lot. So uh, I'm proud that I think that has continued in some states. I just think that's an increasingly important one.
Yeah, as a participant in that, I also, found value in we saw an increased collaboration with folks on the ground, state policy officials, state government, federal government, and so we've seen those improvements too. I tend to I tend to be an optimist, and in aspects of the Medicare program, we have seen great improvement. So when I started, we were implementing Part D. Now in the Part D program, we do have an out-of-pocket cap. And for the folks that are listening, we also had an increase in the low-income subsidy. This is the program that helps low-income people afford their drugs. So we've had some improvements, and we've also seen some major improvements in D-SNPs. But I want to talk a little bit about the reality that we are living in right now. So we have the passage of HR 1, known as the Big Beautiful Bill, and that's making some very big changes to Medicaid. Most of those changes are uh, really aimed at immigrants. And we've heard claims that older adults and people with disabilities were not going to be impacted by HR 1. This is a little bit, I'm kind of leading you down down a path here, but what's your take on it? What are you concerned about?
Well, okay, the belief among some members of Congress that there's no harm for older adults has to start with the fact that you're ignoring those immigrants who are newly made ineligible for Medicare. So
Yeah.
that's like exposing kind of like
Page one,
number one,
right? Yeah.
right? Number two, the bill imposes a 10-year moratorium on federal implementation of two sets of federal rules that would greatly simplify access to the Medicare Savings Programs, which I hope we'll talk about in a little bit, and other parts of Medicaid. One, like the rule on the Medicare Savings Program alone would save $19 million of red tape each year for applicants. It would save states 2 million hours of their own administrative burden, and it would get about 860,000 more people access to more affordable coverage. Now, the states can still implement many of those things, and I hope they will, and let's come back to that. But so number two is that like very explicitly, this bill prevented Medicare beneficiaries from accessing the kind of subsidies that make their coverage affordable. It also like vastly expands the administrative state, and there's unambiguous harm to Medicare beneficiaries from that action. Third, there are hundreds of billions of dollars in Medicaid cuts, as you know. If those are fully implemented, there is a very high likelihood that results in downstream cuts to the kinds of programs that support people to live in their own homes, those home and community-based Medicaid programs, for various reasons. So that is like a future concern that we should have our eyes wide open to. And then fourth, many of the health provisions focus on work reporting requirements to be eligible for Medicaid or every 6 month eligibility redeterminations for certain types of people who are on Medicaid. There's a very real risk of direct harm to some older adults and people with disabilities. And our friends at the National Health Law Program have done a really great job of kind of helping shine a light on some of those. But there's also real risk of indirect harm. we know that there are amazing people in state government, right? But they are constantly strapped for resources, and just I, I'm very concerned that their attention has already focused to implementing some of these new requirements at the potential cost to making it harder for other populations to get expeditious enrollment into Medicaid. Right. So I just think there's a bit of a balloon squeezing here. And unfortunately, if we squeeze it away from these populations, I think there's an indirect cost to that too. So all of these all of these are very real risks and in some cases very immediate harms to Medicare beneficiaries.
As devastating as the COVID pandemic, has been, we did experience some policy changes that came out of the public health emergency that were very positive. And I'm wondering, during this time too, as we're bracing for the implementation of these Medicaid cuts, is there any glimmer of hope of reimagining what's possible? And, for your own reflections on the public health emergency, what did we learn from that? How much has been retained? How much are we losing right now, and can we get it back? Do you have thoughts about that?
Yeah, I don't want to grasp for that silver lining. Here's one. Even while it's critically important that folks in the advocacy community kind of defend against the worst possible harms of the next few years in implementation of HR 1, we still have many opportunities to simplify the way people access Medicare and Medicaid for other populations. You have led the work to do a lot of that in New York State by simplifying, removing the asset test as it applies to the Medicare Savings Programs, for example. You are in New York, where anybody who's on supplemental security income or SSI, low income people with disabilities, older adults, anyone in SSI in New York is automatically enrolled in Medicaid.
Hmm.
I'm in Virginia, where anyone on SSI is not automatically enrolled in Medicaid. They have to separately file an application, even though 99.9% of them are eligible for Medicaid. And so I'm in a place where like I hope the Commonwealth is asking itself like hard questions right now, like do we need to be reviewing 150,000 Medicaid applications every single year at the same time that we have for SSI recipients, at the same time we're taking on these incredible new challenges. And so I do hope, or do we have to be applying some of like the hardest to implement asset restrictions for enrollment in the Medicare Savings Program? I hope states are asking themselves these questions like, can we simplify something elsewhere in our system? Maybe something that we
Yeah.
should have simplified a long time ago for the purposes of freeing up resources to implement some of these new challenges. And I do think we learned some like really important things through the pandemic. We more jargon. States have certain abilities to automatically renew people's Medicaid eligibility. We call that ex parte renewal.
Hmm.
And through some great work by people on the technical side of the house in what was previously known as the United States Digital Services, we made some like really meaningful progress, and the states made meaningful progress on improving their ex parte renewal rates. And these sound like really bureaucratic and abstract concepts, but that's like thousands of people who didn't lose their eligibility when it
Yeah.
came up for renewal. And that's like really meaningful impact on people and the providers they serve them. So yeah, I do. There are silver linings from this, just like there are good things that came out of the pandemic.
Hmm.
And I think like increasingly asking ourselves the questions that you asked for many years, but in some states we just haven't asked about how we can simplify the system. I hope that's a byproduct that comes from all of this.
Yeah, I often say, it can be really annoying, frankly, to have to be spending resources enrolling the same people over and over because there hasn't been a systems fix. And I know in New York, we're trying to advocate for a benefits enrollment system that integrates eligibility because, well, if anything is clear now, we know the data's out there. We know that the state and the federal government have lots of data that can be looked at and checked. And so why are we making people jump through multiple hurdles? The Medicare Rights Center, we participated in a task force at CMS on the Medicare Savings Program. And that's the program where, I cut my teeth doing this work. And the number of administrative hurdles someone has to jump to get enrolled into the program is just incredible, depending on the state you live in. You could have, a page application you have to fill out. It has to be paper. In other states, you can do it this way. We just launched an online application in 2026 in New York, which is great, but it took us a long time to get there. And so thinking about the Medicare Savings Program, I see it as an anti-poverty program. It lowers people's drug costs and increase their Social Security. I want you, first of all, I'm going to set you up here. I want you to take a little bit of a victory walk around some of the policies that were, implemented to improve MSP access, and then also reflect on why is it so difficult to connect people to these programs, and what might you be focusing on in the future?
Yeah, I'm glad you phrased it that way. Thank you for the opportunity to feel good about some forward progress on these, all of which made possible in part by having an MRC alum that I've had the chance to work with over the years, Kim Guan, and many others too. All right, this is more jargon, so let's talk about the Medicare Savings Programs, which not everybody thinks about those names. These are the programs through which you enroll, usually through your state Medicaid agency, and the state covers your Part B premiums and in many cases, your Medicare Parts A and B cost sharing too. And they automatically get you the Part D subsidies too. Affordability is this incredible buzzword politically now, but this is 40+% of the callers to your Medicare Rights Center helpline are calling about affordability issues. More than a third of Medicare beneficiaries report delaying care or going without care entirely because of cost-related issues. And these are disproportionately acute for people with disabilities, for whom more than a third report having trouble paying a medical bill in the last year. So these are so concrete. There's lots of ways to reduce cost burdens, but the most direct one are the Medicare Savings Programs because for the reasons we talked about. And it's not just improving access to your medical care, but I love the way you framed it. It's about anti-poverty. It's an economic security program. We forget this stuff, but most Medicare beneficiaries pay $202 a month now for their Part B coverage alone. If you're at the poverty level, that's more than 15% of your income. So you're living on $14,000 a year to begin with. And then we take 15% of it out just to be enrolled in Medicare and have coverage. And God help you if you go to the hospital and have to pay the inpatient deductible. So these are enormously impactful things that are poverty programs. And to some extent, in our healthcare world where we've been so obsessed with talking about social determinants of health lately, I think it's important to think that getting people in Medicare savings programs is our biggest social determinants of health intervention out of CMS too. So these things are profound and important. But for all of their importance, there are literally millions of Americans who are eligible to be enrolled in the Medicare savings programs, but are not. And they're having that $202 deducted from their Social Security check, and they're foregoing care or forestalling care because they can't afford the cost sharing involved in that. So despite the amazing work you have done, this is a social failing that I think we should look in the eye, and it has many causes. One is that I think we still have limited awareness of these programs, and that's to some extent a byproduct of the weird federalism dynamics at play. But a lot of it is just the sheer complexity of the application process itself. And so you know this, but states have opportunities to greatly simplify it. You have shown the way in New York, but I'll be really clear, this is not a blue state phenomenon.
Yeah.
Louisiana has done a lot of the same things that New York has done to simplify access to the Medicare savings programs, as have many states around the country, but many more still have a long way to go. So if you're a governor, if you're a mayor, if you're anybody who cares about poverty among older adults and people with disabilities, you really have to think about these ways to simplify. So we can make a dent in senior poverty. We can improve access to care, and we can make government simpler to administer, all without inventing a new program, just by
Yeah.
making it easier for people to get into something that Congress already created for them. And so, like you, Fred, I obsess over this because it solves so many social problems all at once, and we don't have to create something new. We have to make something easier.
And so Tim, a couple years ago, I was celebrating a federal rule and annoying everyone in my office, asking them questions about, do you know how states are using the information that Social Security sends to the state Medicaid agency to enroll them in the Medicare Savings Program, who's doing it really well, who's not. There wasn't a lot of information out there. And then HR 1 comes along and puts a moratorium on it. But states can still move forward and help more people enroll into the MSP by using the information that they receive every month from Social Security. They could still work to improve this system, right? They don't have to
Yeah.
stop the
A-
work.
Absolutely. Congress put a moratorium on the federal government from enforcing certain rules that were meant to simplify the programs. They didn't stop what states have always had, which is the opportunity to um, essentially simplify various aspects of the eligibility process, period. And number two, as you're alluding to, like some people apply for certain subsidies through for the Part D program, and it's totally separate. It's crazy that we create a system this way, but it's totally separate from the system where you get subsidies for the Parts A and B programs. Congress kind of tried to address this by telling the Social Security Administration to share all of their information with the state Medicaid agencies. States have not totally maxed out their ability, in fact, they haven't maxed out at all their ability to use those data for the purposes of helping people enroll in programs. There are many very technical reasons for that, but it remains like this really important opportunity. Um, and so there's just so much more we can do. Some of this has to be on the state, some of this has to be in the civic tech community, but some of this has to be like us thinking about policy variables too. And maybe we just need to simplify this system instead of like inventing workarounds for processing new data. I think all need to be at play if we're serious about getting people more affordable healthcare and helping them like access the programs that Congress designed for them.
Yeah, I do have a lot of empathy for folks that work in the state government who are implementing these programs and trying to improve and implement new policies. And then all of a sudden you realize that because Medicaid eligibility is so complex and data systems that they're dealing with a lot. So sometimes, as advocates, we sit down and we say, okay, this is what you need to do better. We want to see this. This is what the problem is. And so you've been on the receiving end of, requests from advocates, and you also now in your new role, where we're going to talk about that, you're going to be probably sitting with members of Congress and policymakers. So what do you think a member of Congress needs to hear or better understand? And then a follow-up to that is like, what advice do you have for advocates out there, whether they're at the state level, so maybe they're involved in a state coalition, or they may work for a national organization? Like, what advice do you have for advocates? And is there, I mean, I granted you'd be sharing a tip with, nearly 500 people, but what tips do you have?
Well, I think it's important for us to remind policymakers, right? Like it is so when we're sitting here doing it, it is so easy for us to criticize these public programs. But both you and I know that Medicare and Medicaid are profoundly successful, right? Like they're amazingly impactful programs. So I never want our critique to be perceived as like, like we should throw these things out or reinvent them. They're amazingly successful. And their successes, I think it's important to remind ourselves, like we should think of them as investments, right? They're not sunk costs. When we spend money to get dental services for someone or help them get out of bed in the morning and navigate
Mhm.
the world, those are investments. And if we want like a vibrant and competitive workforce, we need to make investments, not just in healthy people. We need to make investments in everyone. And this is a big part of how we do it. I just think number one is we have to remind ourselves that these are incredibly successful interventions. If we had this conversation 60 years ago, we'd be talking about
Yeah,
senior poverty in like a completely different way because
yeah.
these things didn't even exist. And so, number one, step back, like these are incredible and important programs, but they are too complicated. And like that is not look, I was a pointy-headed bureaucrat for a long time, like, but the complications are not the fault of some deep state boogeyman. Like a lot of them are because of the policymaking process and the kind of like policy kludges we have built over the years. And so I do think we need to remind policymakers that sometimes like inventing the new thing isn't like as important as simplifying and fixing kind of like the existing programs. And that's a really tough like message to deliver to people. Um, I'm in no place to criticize anybody or give advice like relative to you, but I think on the advocacy side, I, I am the embodiment. I have already embarrassed myself here multiple times with how little I understand about programs I've worked on for a long time. So I'll tell you too, I think sometimes people in CMS or in the state Medicaid agencies, they don't have the same perspectives as you do on the advocacy side. It's not a difference in like intelligence or something. It's the fact that on the advocacy side, you're much more often experiencing the system as like
Yeah.
real people experience it. And on the government side, you're experiencing the system through the lens of like some very specific thing for which you are accountable to like elected officials and you want to do a good job managing the physician fee schedule or like whatever thing you're in charge of. And that is so complex and so important. At CMS, there are brilliant people who work on these things, but the system they work on is so inherently complex and in many cases like confrontational with a broader public that like you can't also spend the time to experiencing the world as a low income older adult does. And so I think to some extent the message I would deliver to the advocacy side, informed by my own limitations, is that you shouldn't always expect that even the smartest and best intended of public servants have seen the world through the lens that the advocates have seen the world. And I think that's like it's just important to like recognize that as no one's failing, but there's an educative element that maybe seems really basic to people. And then secondly, I do think we collectively have, I think, an opportunity and an obligation to some extent to make policy fixes really crystal clear and specific to people. I know myself, I've embarrassed myself with some advocates by thinking like, hey, I just thought of this solution and we just did it. And then Kevin Prindiville at Justin Aging says, well, great job, dummy. We've been telling you that for 10 years. And so I think to some extent, we just need to make sure that we're always communicating between the public sector and the advocacy side to like make sure that we're really crystal clear and operationally specific about the fixes because it's really easy to talk past each other and that's easier said than done. But I think is an important part of what you guys do and what I hope we'll be doing.
Yeah, I often think that we often don't understand also how challenging it is to have to work within a certain system that has, maybe outdated, it has technical requirements. We don't see all that. We come in with the ideas and then maybe there's a point in time like the public health emergency that emerges and then all of a sudden ex, automatic renewals, telehealth coverage for Medicare, it all becomes crystal clear to everyone at the same time and we all seem like we're on the same page after, a lot of hard work. But and to your earlier point too, I always remind myself, we run a helpline. The Medicare program is very popular. It is working well for most people. When I am having conversations, and you probably had this happens to you too, anytime anybody knows that you somehow know something about Medicare, you are talking about their Medicare eligibility at the oddest holidays, the oddest times, etc. And it's just a reminder that it is working very well for many, many people. When you run a helpline, you're going to oversample completely for the issues and the problems. And that's the point. We have a lot of qualitative data, et cetera. And to your point around, the importance of these programs. And so when you think about Medicaid and home and community-based services, it is a privilege to be able to help individuals that are in need of these services because they are so essential to everything that they do. Um, Tim,
Fred, we talked about some of these in the context of like economic security and
yeah,
anti-poverty. I think we should think of them too as civil rights programs, right?
yeah.
For people with disabilities, their ability to interact with the community are like very often derivative of what they can access through Medicaid coverage. So like you cannot overstate how important these things are. They are not just healthcare programs. They are programs that are affect Americans' ability to like interact with dignity and independence in their communities. And we can't emphasize that enough.
Well, and that's why it really stood out to me, Tim, when I learned of the launch of the Aging and Disability Health Policy Lab, that you say in it aging and disability. It is crystal clear. So, can you tell us a little bit about that? A number of us are very excited to have a new entity out there advocating for reform. So, tell us what it is. What are you going to be focusing on? What are you excited about?
Yeah, thank you for that. We have a new endeavor. You named it well, the Aging and Disability Health Policy Lab, where our mission is to improve access to healthcare and long-term service and supports for older adults, people with disabilities, by advancing good public policy. We'll do that work at the state level, we'll do that work at the federal level, and we'll do it in a totally nonpartisan way. And we'll do it with like three really basic steps. Number one is, as we've emphasized here in this conversation, listening to the lived experience of older adults and people with disabilities and their experiences and challenges with healthcare and long-term care. Number two, it's developing actionable, concrete, technically specific model policies.
Hmm.
That might mean model state legislation or federal legislation or regulatory language, but very specific policy fixes to some of the very technical issues that you and I have talked about. And then partnering with the local and national organizations, I hope, including the Medicare Rights Center, to get those policies circulated to the policymakers who can act on them. We talked about the challenges of running a state Medicaid agency or being a public servant. Incredible challenges too of being a state legislator. Like even in this conversation, we've used such impenetrable jargon, and
Yeah.
and in most states, state legislators have other full-time jobs and have portfolios that include education and the environment and criminal justice and so many other things. And so I think we owe it to the policymaking community to make it as simple as possible to like help them by providing them the really specific and concrete solutions for the kinds of public policy programs that vex people on both sides of the aisle. So we'll focus on policies that simplify a healthcare system that has become totally overwhelming for people to navigate and for governments to manage. And that means embracing some of those technical details and going deep into the plumbing of these big, important, major social insurance programs. So I'm grateful you they had a chance to talk about. I
Excellent.
am grateful for the SCAN Foundation, who has funded much of made this work possible and had the vision, I think, encouraged to focus on some of these like really important, but let's kind of face it, like technical issues and realize that this is how we make a really tangible impact on the people that we care about. We don't we exist in certain ways. We won't have a website until probably late April, and when we launch, we'll start with some model state policies on simplifying access to the Medicare Savings Programs that we've talked about here, and I hope will be our first small, but first meaningful contribution to trying to make it easier for policymakers to solve some of these incredibly technical but impactful and tangible challenges for the people that you and I care about.
Excellent. Yeah, and one of the questions that we got from the audience is it's a pretty basic question, but going back to the MSP, someone is asking, are is the MSP program administered in every state? How does that work? And so maybe if you could just talk a little bit about that and what we're both jointly trying to accomplish with improving MSP access.
Yeah, to enroll in the Medicare Savings Programs, you primarily do that by applying through the state Medicaid agency infrastructure. So in many states, that's a county level Department of Social Services or something like it. And if you go to your state Medicaid agency's website, there's often information about how to apply for those types of programs. In Medicaid eligibility jargon land, sometimes you don't hear the term Medicare Savings Program. You hear these other terms like QIMBY and SLIMBY or qualified Medicare beneficiary or special low-income Medicare beneficiary. They all kind of get you to the same place. You don't really have to know the difference between those things. You just need to know that there are programs out there that can help low-income people cover their Part B premiums. And in many cases, there are other Medicare cost sharing, and they are grossly undersubscribed. So people should apply for those because many people are eligible and just haven't enrolled yet.
Yeah, I often forget when one is so steeped in this information that there's nothing simple about it. Like just hearing Quimby, Slimby, QI, and as you mentioned, the fact that state legislators and also state agency officials have to understand these programs, implement these programs, and something that may seem like a minor tweak actually is a little tricky. And most of the time that we've spent was just around educating around the importance of the MSP, why it needs to be expanded, why people with Medicaid all of a sudden when they turn 65 have to manage a very tricky transition into Medicare enrollment, et cetera. And so, yeah, I guess,
Fred, wait, we'd be remiss. There's one other important piece of advice that if you're lost on
yeah,
that, I encourage people, you can always contact your local SHIP, Senior Health Insurance Program, but you
Yeah.
can also call the Medicare Rights Center
Oh,
National
there you go.
Helpline at 1-800-333-4114. That's 1-800-333-4114. You call on a Thursday morning, you may
Oh,
just get, you just may get a really skilled volunteer.
and make sure to bring a very technical question to that volunteer. I think on that note, Tim, I just want to thank you for spending this time and for all of your work. We're really excited about what's coming next. Just to step back, MMCO has put billions of dollars back in the pockets of the lowest income older adults and people with disabilities in this country. And so I just want to thank you for your service at MMCO and the fact that we can continue to partner together to expand access to these important programs and more. So just Tim, thank you so much, and excited to see what
Fred,
happens next.
thank you and thank your entire team who do amazing work and have taught me so much and so many people so much. So thank you, Fred, for the opportunity to be here and the opportunity to work with you, but so many other great people at the Medicare Rights Center.
Great. And thank you everyone for joining. See you soon.